Good afternoon, everyone. Good afternoon. I'm just giving folks a couple of minutes and then we'll get started. I'm excited today. We're going to be talking about birth control options. Okay, we'll go ahead and get started. Good afternoon, everyone. I'm Dr. Madeline, your board-certified OBGYN and public health advocate. I'm a fierce warrior for health equity and hoping that we can get women to a place where we can have more control. So today I'm excited because we're going to be talking about birth control options. And birth control is something that many of us as women have to deal with in our lifetimes. Reproductive health years in most women are between the ages of 15 and 44. When you see people publish different reports and everything, that's the age range that they're talking about. But really, the place where women might be at risk for an unplanned pregnancy is after they have their first cycle, which is usually the average age is about age 11 to 12 in this country, and until their last cycle, which is about age 51 in this country. So if you can imagine, that's 40 years, almost 40 years for most women, when they have to think about and consider all the different things that might be going on in their life, whether it's education, whether it's work opportunities, and certainly planning a family for many women is something that's of paramount importance. And so today what we're going to do is try to dive into what are some things to consider for women who are exploring different birth control options, things that might be short-term, things that are longer-term, things for them to think about in terms of if other things are going on with their health. One of the things that I'll dive into in a future live session is birth control options for women to consider if they have other medical things going on, like for women who have high blood pressure or women who might have a history of headaches and other things that could make birth control use complicated. We're going to spend some time talking about that as well. So let's get started, because certainly there's a lot of information out there about birth control, the different types of birth control that are available. And I want to have some time to answer questions. If you have any, you can type them along in the comments section, and certainly we'll get to them at the end of the discussion. And so one of the things to think about, I want to give you a few numbers that you can think about as we consider different birth control options. So one of the numbers I want you to, hi, Dr. Banga, thank you for joining. I appreciate you being here. So one of the things I want us to think about when we think about birth control is, one of the things I want us to remember as we think about birth control is, again, the vastness of it. So if we look at the numbers in this country, we think about, how many women might need to access birth control at some times in their lives. And there are about 61 million women in this country who at any given time are between the ages of 15 and 44 years old. And of those 61 million women, about 43 million, 70% are at risk of unintended pregnancy. And that's an important number to keep in your mind. Of all the women in this country, whenever they do the different estimates, unintended pregnancies happen about maybe 50% of the time. And so it's important to think about that and also consider different options in terms of birth control options. So when we look at it another way, if you think about male and female partnered couples, those who do not use any form of birth control or contraception have about an 80% chance of having an unintended or unplanned pregnancy. Now, I do want to clarify because certainly many of us, me included, I've had unintended or unplanned pregnancies. Sometimes those pregnancies are still desired, but I'm really focusing on talking to those women for whom a pregnancy may not be desired. And so birth control comes up frequently in conversations with your GYN if that's the case. So what I'm going to talk about first is an increasingly popular form of birth control, and we call them LARCs. And LARC stands for long-acting reversible contraception. And so the two main forms of LARC that are available in this country include an intrauterine device and also an implant that can go into the upper arm. So an IUD, there are several different types on the market right now. And again, they're becoming increasingly popular. You can have an IUD that can just stay in for a couple of years, 3 years. You can have a type of IUD called a Liletta that's very popular. It has some hormones in it, and that can stay in for up to 6 years. And you can have a Paragard, that was the one I really enjoyed, that can stay in for as long as 10 years. The Paragard is really great for women who have no other medical condition or have medical conditions because it doesn't have any hormones in it to make certain things with their health go in a bad direction. And so IUDs, I have one here actually that I want to show you because sometimes people have questions is a little part of the string is allowed to stay outside of the uterus through the cervix so that the string can be checked to make sure it's in the right position. Also, the string is sitting outside of the cervix so that when it's time for the IUD to be removed, the string can be grasped by your provider in the office and pulled out. Now, it's always funny. Many GYNs have stories of patients whose oh, sorry, I had some technical difficulties, but the internet is back. So I have, so this again is an IUD that can be removed. And I was saying that sometimes patients have funny stories of either their partners removing it for them, depending on what's going on, or it falling out. That can happen sometimes. And so one of the things we always recommend when we, in between when we see patients for their annual visits, is that if they can, they place their hands inside their vagina and just touch the string to see if they feel it there. Many patients don't feel comfortable doing that, and that's fine too for them to come into the office and just check to see if it's there. Now, I don't have here another popular form of a long-acting reversible contraceptive called a Nexplanon, but that's the implant that goes into the arm. It's actually not much larger than the IUD. Imagine that it's just a flat, solid rod that's about as long as this. And what we do is, and it lasts for 3 years, and most times what we do is after cleaning and numbing the area on the upper arm, we insert it using a device. It takes, just like the IUD placement, it takes less than 5 minutes. And so when they're thinking about long-term, again, reversible contraception, and they're thinking about something that can be inserted easily, less than 5 to 10 minutes, and then also removed easily, less than a couple of minutes, this is one of the things that that they can consider, the next and the IUD. So those are both long-acting reversible contraceptives, and so definitely keep those in mind. If you are seeing your provider and you have questions about something that that you know would last a few years, that you don't want to think about every day. That's another reason that LARCs are very popular, because sometimes women don't want to think about them every day. I know when I was in my 20s, I had the hardest time trying to keep up with taking a pill every day. And so I often have patients similar concerns. You know, they don't feel comfortable, or they keep forgetting to take their pill, and they don't want to have any slip-ups. And so certainly LARCs are great to consider for that group of women who are looking for something that's long-acting but also reversible. The two most commonly used types of birth control in this country are actually the pill and also tubal ligation. And then after that, condoms are also very popular. Now the pill, again, like I said, it is something that people have to be mindful of, trying to remember to take the same time every day. But what people like about it is that if they just want a short term of contraceptive use, if they know that they might be interested in getting pregnant in the coming months, or maybe less than a year, then sometimes people like the pill because you can be on it. It's short acting. It doesn't, when you stop the pill, the hormones leave your system relatively quickly. And again, as long as someone can remember to take it every day, it actually is very effective. Let me go back and say that in terms of the LARC effectiveness, when we talk about effectiveness, we're talking about how successful is that method in doing what it says it's going to do in terms of preventing pregnancy. Now, the IUD and the implant are about 99% effective. What that means is that of 100 women who take either of those LARC methods, only 1 out of 100 will get pregnant. That's not bad, right? And a lot of times the 1% is, depending on the method, might be due to user error, might be due to the method actually slipping out of place, and so that's good to know. Now, the effectiveness rate for the pill, even though it is a very popular method, is less effective. It's in the lower 90s, and again, it ranges depending on user error. So if a woman is able to be very consistent with it, and sometimes it's not even the patient themselves, they just might have a lot of stuff going on. It might slip their mind, like it used to happen to me in the 20s, and you'll find that the effectiveness rate is in the low 90s. So not as effective as the LARCs, but still very effective if you can remember to use it as prescribed. The condoms are also very commonly used, and I want to say this as a caveat to all the different methods that we're talking about today. These methods, when I say they're effective in preventing pregnancy. When we talk about prevention of STDs, and including HIV, or human immunodeficiency virus, those methods also require condoms to protect against STD and HIV. Okay, so just something to think about as you are considering different options. Now, I mentioned tubal ligation. So tubal ligation is a popular method for women who might be at the place where they've decided that they are done with childbearing. They've had all the children they plan to have, and they would like to have their tubes tied. Now, tubal ligation happens in a variety of ways. I don't have a picture with me. If you can imagine the uterus here and you have the fallopian tubes coming out, many times people, when they say tie their tubes, sometimes patients, if they're asking me questions in the office, they'll ask about if it's a true tie, whether I'm actually going to tie a string so that if they change their minds in the future, the string can be untied and they can again achieve fertility. Most times when people get their tubes tied, it should be considered permanent sterilization. So the way we tie tubes, some people tie and cut and burn the tube. Some people like to put on something called Filshie clips. Other people like to take the end portion of the tube where the fallopian tubes are, where the fimbriae are, just as a way to even more decrease the chance of an unintended pregnancy. But whichever method you get, when you are considering a tubal ligation with your provider, absolutely consider it permanent sterilization. There are some providers who do procedures where they try to, we call it reconnect or reanastomose the tube if the person changes their mind in the future. So that's also something to consider. Now, what should you do if you are someone who is interested in tubal ligation? So a couple of things to consider. If you are 21 or older, because most people won't do it below age 21, and most places it's not legal to do so, it's really important that you think about whether or not you are absolutely positively done. I sometimes have patients who might be in their early 20s, but they might have 4 children and they're absolutely positively done. And there are some cases in which I will go ahead and tie their tubes. However, there are patients who, I always have this conversation with patients, and this is important to remember as well. So when you are 23, and studies have shown this as well, if you do get your tubes tied, when you get to about age 30, you are more likely to have regret about tying your tubes. And so that's why it's really important to think of it as a permanent sterilization. And when I say regret, I mean, for many women in their early 20s, we think we know everything. We think maybe we've met the one. Sometimes that's not the case. So there are times when women get their tubes tied in their early 20s, and when they turn 30, they meet a new boo, and that new boo may not have any children, and they are interested in having children with that new boo. And so it becomes complicated if their tubes were tied in a way that another provider, another doctor can't come in and put those tubes back together. So again, just something to think about. Sometimes for my patients who are in their early 20s, I might talk with them more about one of the LARC methods, the IUD or a Nexplanon, an implant, so that they have a few years to really think hard about whether or not that's what they want. So I wanted to just mainly talk about those. There are some other methods that are used, I think, less commonly. There's the patch, there is the vaginal ring. Another popular method that many of my ladies like to use is the Depo Provera shot. It's a shot that you can get every 3 months. It goes usually in the arm. Most women like to get it in the arm, and it's very, very effective. It's in the mid to high 90s of effectiveness if a woman gets it every 3 months as prescribed. It works very well. The main thing that women complain about when they get the Depo Provera is the side effects. The side effects can range from irregular cycles. Sometimes that bleeding is heavy. Some women complain of weight gain. It's important whenever you're sitting down with your provider or your partner and you're talking about different birth control options, really, really try to understand the different side effects and risk factors that go along with with these different types of birth control options. And so I control options today. When I touch base with you guys in the coming weeks, one of the things I want to do is to go a little deeper with some of the options. So, the reality is that when we're taking birth control, that doesn't exist in a vacuum. We take birth control, but we might also have, some people might have high blood pressure. Some people might have a weight that's toward what we call a higher BMI. Or some people have sickle cell disease. There are birth control options that we consider differently depending on what else is going on with someone's medical scenario. So in the coming weeks, what I will do is take some time to dive in a little bit deeper with some of the methods and really talk about, which methods are more likely to cause some irregular bleeding, which ones are might be considered for someone who has multiple medical problems. And I look forward to talking with you about those more and also responding to your questions about the different methods of birth control. So please, by all means, I'd love to hear from you and get more questions and be able to answer any questions you might have. You can find me on Twitter at Dr. Madeline MD, also on Instagram at Dr. Madeline MD, and here on Facebook, my page is Dr. Madeline. So I really thank you for your attention today. Thank you, Dr. Banga, and also I see Dr. Kimmy. Thank you both for joining, and I hope you enjoy the rest of your afternoon. Thank you.